So what brings you in today? What happened?
About 3 weeks ago, I was starting to have very odd sensations go down my left leg, and the pain comes and goes depending on what I'm doing, and sometimes I also have hip pain in the same side.
Okay, so based on location, you kind of already just answered that question for me. So left hip, but it travels down the back of your leg or the front of your leg?
The back. It changes, but I mostly feel it in the back of my left leg. Sometimes it goes all the way down into my calf.
Okay. Was the onset right away, or did it take some time to get to where it is right now?
It was a gradual onset. It began with pain just in my glute, isolated there, and then it increased the pain going down the leg.
Okay. What type of pain is it?
Most of the time it's achy in those areas, but sometimes I get a shooting pain, and that is very sharp, and it goes all the way down the leg. And sometimes I even get a burning sensation there.
Okay. If you were to rate your pain on a scale of 1 to 10, when the worst it's ever been, where would you put that number? 10 being hospital-related pain.
Usually the ache is about a 4 out of 10, but when I do get that shooting pain, it can get up to about an 8.
Okay. Have you tried anything to alleviate the symptoms or to make yourself feel better?
Moving around and walking has made it feel better before.
Okay. At any point since you've been dealing with this pain, have you ever felt or heard any odd sounds or sensations?
No, not so far.
Okay. Is there any other symptoms that we haven't covered yet that I should be aware of?
No, I don't think so.
Okay. Is there any other health concerns or previous injuries that I should be aware of? So we're looking specifically at any diseases or slip femoral, epiphysis, anything major going on within those hips.
Well, I've had low back issues in the past, but haven't had it go down into my leg like this before. No, I don't have any diseases like that.
Okay. Any steroid or alcohol use?
The odd glass of wine.
Okay. Have you ever experienced amenorrhea or any irregularities with your menstrual cycle?
I went through menopause when I was 55.
Okay, last question. Are you allergic to anything or are you currently on any medications?
I take medication for high blood pressure, but other than that, I'm quite healthy.
Okay, so now I'm going to take a look at you. So what I'm going to get you to do is stand up for me. Okay, so when we're looking at this injury, she was talking about left hip and it going down into the back of the leg. So when we're observing and looking at her, we're looking at her hips as well into her low back a little bit as well. So in a more private setting, I'd probably have her in shorts and potentially a gown to be able to expose that low back. So I'm looking bilaterally at her left and her right hip, looking for any swelling, discoloration, or deformity. Because it wasn't a really traumatic, quick onset type of injury, you're typically not going to have major swelling or any discoloration or deformity with this injury. But we are going to still take a look at our formations and abnormalities. So because we're dealing with the hip, we got to look at the joints below, so the knee and the ankle. So we've already talked about the foot. We're looking at pes cavus planus, any pronation or supination. You're looking at your knee, so you're looking at the recurvatum, you're looking at genu valgus, genu varus. We're also looking at her patella alignment, okay? So if it's sitting high, sitting low, sitting in, sitting out. Lastly, we need to look at her spine and how it's shaped. So when I look at kyphosis, scoliosis, and lordosis, I need to look at two different angles. So we'll start with kyphosis and lordosis. So I'll have her spin 90 degrees here. So when we're looking at kyphosis is going to be an outward curvature of her thoracic spine. Okay, when we're talking about lordosis, we're looking at inward curvature of her lumbar or lower back. Okay, lastly with scoliosis, I'm going to have you turn one more time for me. We're looking at that S shape in her spine. Okay, go ahead and face the camera again for me. So I would be again looking at all views, right? I would be standing in the side, behind, the other side, and in front of her to make sure I'm looking at all views of her hips and low back and posture and everything like that, okay? Gait analysis, you'd have them walk away and then walk towards you to see how they're walking. See if you could pick up on any kind of abnormalities within her walk. Lastly, if it's a younger, active individual, you can have them do a single leg squat. If it's an older individual that you don't feel comfortable based on balance with a single leg squat, then just simply a double leg squat, okay? So what I'm going to get her to do is that single leg squat for me. So, good. And then the right leg. That's right, right leg. Good. And then into your double leg squat. Okay, so I'm standing right beside her so you guys can see her, but typically I'd be standing in front of her to see what's happening with those knees, if they're staying in line as she goes down into her squat. So what we're looking for is the knees caving, simply, okay? So when the knees cave in a squat, either single leg or double leg, we are looking at weak hips with that, okay? So that's why we look at that with this assessment. Okay, so I'm gonna get you to stay right where you are. We're going to talk our way through some palpations. So again, with skin temperature, go ahead and spin around for me. Back of my hand, I'm going to just pretty much put my hand in the area where she has her pain in the hip and see what I'm feeling. Is it normal skin temperature? Okay, so then we're going to go into bony prominences for palpation. So iliac crest is, I always ask my patients first of all so that they feel a little bit more comfortable to take their own hands and place them on their hip bones. So when they do that, I have an idea of where that hip bone is before I start going and touching them and potentially making them feel uncomfortable. So now that you did that, I'm going to get you to put your hands higher, lower, or just out of the way. So I'm going to feel the iliac crest as it comes around to the back. Okay, so that's the iliac crest. Because she's facing this way, I'm going to show you guys the greater trochanter. Greater trochanter is this bony prominence on the side of her leg. So iliac crest is right here. I'm going to work my way down until I find her greater trochanter. Okay, greater trochanter is right here. From there, once I find the greater trochanter, I actually go into now all my glute muscles, because all the glute muscles essentially insert or attach to the greater trochanter. So go ahead and turn one more 90 degrees for me. I'll move to this side of her hip. So again, feeling that greater trochanter on the side of her thigh to then feel her glute muscles, okay? So her glute med is here. Her glute min sits below that, okay? So glute min, glute med. Then we have glute max, okay? That's glute max. Underneath all of that, you have your piriformis. Your piriformis goes from your sacrum out to your greater trochanter, like probably 2-finger width, like this. Okay, that's where her piriformis sits. While she's facing this way, I'll show you guys where her PSIS sits. So posterior superior iliac spine. Generally sits, you got to palpate quite deep to feel comfortable that you're on it. So her PSIS sits probably right about here. Okay, so from here, she has her ischial tuberosity. Ischial tuberosity is your sit bones. It's where your hamstrings insert. So it's directly in the base of the glute right here where all those hamstrings come up and attach. Lastly, while she's in this position, I'll show you guys the path of the sciatic nerve. As you palpate the path of the sciatic nerve, you don't have to be very, very specific. You just got to think about where that sciatic nerve comes and where it travels and palpate all the way down and palpating those muscles that the nerve travels through, okay? So it comes out of your spine, it heads laterally, and then it comes down into your hamstring, the back of your leg, into the back of your calf, okay? So here I'm just palpating, seeing if she has any zingers or any sensations, if I'm reproducing any of that pain that she might be experiencing. Okay, now I'm gonna get you to do a full 180 and face the screen for me. So that's all posteriorly, all the palpations that you have to do. Now you have to do anterior palpations as well. I have her standing for the sake of this video, but I would actually have her prone and supine on the table as I palpate this. Okay, so if you don't mind putting your arm up like that, just out of the way a little bit. So we already know our iliac crest comes around here. The most anterior aspect of the iliac crest is your ASIS, okay? So bilaterally here and here. Once I find my ASIS, I then like to go into my hip flexor complex muscles. So you can palpate the iliacus and the psoas major. The psoas minor sits underneath that major, so it's hard to get to. So once you're on the ASIS, you fall medially, just off that ASIS, and then you're on your iliacus. If you go one more medially, you're now on the psoas major, okay? We've already gone through our hip functional testing with our knee assessment, but I'll run through them one more time. So I'm going to have you have a seat on the table here, facing the screen. We're going to do internal and external rotation. So what I'm going to get you to do is just bring your left foot towards me your left foot in towards your midline. And then again, we're comparing bilaterally, right? So she would do everything we do on the left, she'd do on her right. So now I'm going to internally rotate, externally rotate. Now she's going to do it against resistance. So she's going to push into my hand. She's going to push into my hand. Now that we're done that, we can get into our abduction, adduction, flexion, extension, or functional testing. So why don't we get you laying supine for me? So we'll start with hip flexion again. So all she's going to do is bring her leg up. Good. She's going to bring her leg down. I'm going to do it for her. Good. And then she's going to go up about halfway, and we're going to add a resistance. Okay. And I'm going to push down. Now let's flip all the way onto her stomach into a prone position. She's going to do hip extension. So bring this leg up to the sky on your own. Good. All the way down. I'll do it for her. Good. Now resisted, so she's going to go about halfway, and now I'm going to apply a pressure down. Lastly, we have abduction and adduction, so if you don't mind laying on your side, facing the screen. Abduction, she's going to bring her leg up on her by her own. I'm going to do it for her. Good. We're going to go up about halfway, and now I'm going to apply pressure down. Adduction. Bring your leg up on your own. Good. I'm going to do it for her. There we go. And then she's going to go up about halfway, and I'm going to apply pressure. Okay, so now that we're done functional testing, we'll move our way into our special test. So our first special test is going to be for any pathology or any injury to our SI joint, or it could be called SI dysfunction or a sprain. So it's called Faber. Faber is an acronym for the movement that we put her into, or the position we put her into that comes from the hip. So F stands for flexion, flex the hip. AB stands for abduction, so she's going to come out a little bit, and then we're going to externally rotate. So we're going to bring her knee out and her ankle in, and then I'm applying pressure, okay? That right there is called Faber. Another extra step on this test is to put the ankle on the top of the knee on the other side, and then I'm going to apply a pressure here on the top of the knee and pressure here on the ASIS and push down to kind of torque her low back or her SI joint and see if I can recreate or reproduce any pain coming from that SI joint. Okay, so like I said, that's for any SI pathologies or dysfunctions. Next test is called Fader. Fader is, again, another acronym, so flexion, adduction, and internal rotation. So she's going to flex, she's going to adduct, then we're going to internally rotate, okay? As we do this, if she feels a pinching sensation or sharp pain in the anterior aspect of her hip, it would be something called femoral acetabular impingement, okay? So anterior hip impingement. This is indicative of anything going on in that area. All right, our next test is called Trendelenburg. So I'm going to get you to stand up for me, Shelby, and face the camera. We're going to shift all our weight over to our right leg. As she does that, what I'm looking for is hip alignment. If she has a weak glute medius, which is what we're testing, she would have almost like a hip pop, okay? So she wouldn't be able to support this position, and the thing to go would be the hip out to the side like that, okay? So we're just looking for glute med weakness. Our next glute med weakness test is if you lay on your side facing the screen for me, is simply just the resisted range of motion test that we just did, okay? So she's gonna lift this leg up a little bit. I'd be standing behind her, placing my hand over her hip and onto her ankle or knee, or potentially knee, depending on what we're dealing with, and I'm pressing down, okay? If I'm able to break her and she can't resist that, that's essentially a weak glute med, okay? We also have to flip her over and test the other side to know, compare them to know what her normal is, okay? Our next test in the same position is now going to be for an adductor strain or a groin strain, okay? So in this position, it's the same thing for testing range of motion with adduction. She's going to bring her leg up, and now I'm applying pressure down, okay? Pushing down. This muscle typically feels a lot weaker than the outside hip muscles of her hip, so it's important again to flip her over and compare bilaterally to see what her normal is, okay? So if she has pain and or you're able to break that, maybe they can't even pull it up against gravity, right? So keep that in mind when you're dealing with your muscle testing, or see if there's any weakness or strains within those muscles. Our last one is resisted hip flexion. So she's going to lay on her back again. This is for a hip flexor strain. there's two different ways to do this. Our last assessment, I had her doing the Thompson test with laying on the edge of the bed and she fell backwards. You can resist a hip flexion in that motion as well. It's a little bit more aggressive than what I'm about to do now, so I'll show you this version of it. She's going to pull that leg up just a little bit off the ground. She uses her hip flexor to go into hip flexion, right? Once she's in this position, I'm again going to try to push her down. Okay, we're looking for weakness or pain comparing bilaterally. Okay, so that is any sort of muscle strains or tears with all those manual muscle testing that we just did. Resisted hip abduction, hip adduction, as well as hip flexion. Okay, so our next one is for a labral tear. It's called hip scoring. So we need to essentially load that ball and socket joint and compress the labrum within that joint to see if there's any tears. Once we compressed it, it's kind of like our McMurray's test with our meniscus. Once you add that compression of that joint, you then have to get like a grinding or a rotation to see if we can reproduce any pain within that joint, okay? So what we're gonna do is we're gonna bend her knee and her hip at a 90. Instead of McMurray's test, I was applying pressure together like that, but for hip scoring, what I'm doing is I'm actually pushing the hip down, okay? It's quite aggressive. If I have a really big, like for example, football or hockey player that's quite big and the table's too high, I will get them on the ground to apply that pressure down to really load that hip joint. So in this position, I'm loading down, and then I'm scoring it, rotating it, to see if I can reproduce any of that pain within that joint, okay? She's gonna feel pain, maybe some catching sensations as well in there for it to be a positive test. Okay, so we have 2 more tests to do, technically 3 more tests to do for SI dysfunction. So the first one's called SI compression and distraction. Compression distraction is just as it says, you're simply compressing the S joint or distracting the SI joint, okay? So compression, I'm taking my hands on both sides of her iliac crest. My thumbs are on her ASIS and I'm compressing them together, okay? So here, pushing together, okay? Distraction. Distraction, I'm now pushing the ASIS away from each other, okay? So I'm gonna use a palm on this side and a palm on this side, and I'm gonna push away from each other to then distract those ASIS, okay? So ASIS, ASIS, and I'm applying pressure and separating those 2 bones to see if I'm reproducing any pain in the low back, okay? So that was SI compression distraction. The next one's called Gainsland's. So Gainsland's test is our last test for SI dysfunction or sprain. So what you're gonna do for me, Shelby, is you're going to take your right knee. First of all, let's shift our body all the way to the edge of the bed. I want you to bring your right knee up to your chest, and then holding my hand here to support her so she doesn't feel like she's gonna tip off, I'm going to take this leg and bring it out to the side, okay? In this position, I'm pushing down here and down here, okay? When I apply these 2 pressures, I'm actually getting a rotation that's coming from the SI joint. So that's how I'd reproduce any pain that's coming from that area. Okay, last test. Our last test is called Lasag's. Lasag's is for sciatica or piriformis syndrome. So I'm going to test her left leg. I'm going to bring her leg all the way up. She can tell me when she feels hamstring tightness. Okay, so right about here. From here, I'm going to back off only about 5 degrees. From now, I'm going to take her toes and I'm going to dorsiflex her foot. As I do that, I'm taking that sciatic nerve that runs all the way from her low back and I'm essentially adding a tensile force to it, or a stretch force to it, okay? So a reproduction of burning, numbness, tingling, sharp shooting pain to her toes, that's kind of what I'm looking for, reproduction. If she has any of that, that means she potentially has sciatica or any sort of piriformis syndrome, okay? If she doesn't have any of that type of pain, but she still has pain in the back of the hamstring or the back of the knee, she simply just has hamstring tightness.